Hello, friends. Good morning, one and all. I'm sure you'd all rocked your NEET Super Specialty examination, and we as a team are extremely happy and proud to see all the messages from our students to see how well they have done their examination. And we hope and pray that you all, because of your extreme hard work, will be able to get the super specialty of your choice without any doubt. And with regards to pediatric surgery, I'm really happy that nearly most of the questions which we have discussed in our classes have been asked in the examination. So I just put up an overview of what all questions have been asked in pediatric surgery and certain insights and what all points we've already discussed in our classes. We just directly go into our questions. So the first question which was asked was on NUS procedure. Okay, NUS procedure, as we have already discussed in our classes in a lot of sessions with regards to chest wall deformities, we know there are two. One is a pectus excavatum, another one is a pectus carinatum. So NUS procedure is used for pectus excavatum, where you can see a chest which is gone indrawn, it's gone inside. So what do? We put in a thoracoscope and then we usually insert a metallic bar. This metallic bar is inserted from one end of the thoracic cavity and then it goes inside. The adhesions between your pericardium and the sternum are being separated, and this goes to the other end. Once it goes to the other end, it is turned. So usually it will be like the concavity facing you, and once it goes inside to the opposite side, this metallic bar is turned in such a way that your pectus excavatum just pops out, and this classically is known as a NUS procedure. You can see again a scope is put here. You put in a metallic bar from one end. This metallic bar goes to the opposite end. Once it goes to the opposite end, it is turned in such a way the convexity faces to the outside and the pectus excavatum is completely corrected. So it is chest wall deformity with the anterior chest wall is caved in or sunken, and it's 5 times more common in a pectus carinatum, where there will be an abnormal outward project protrusion. And we all know the most common index, which I've already discussed in all our classes, is Haller's index. Haller's index ratio width of the chest wall to the depth of the sternum. You can see the maximum transverse diameter to the minimum AP distance, and Haller's index will give you a clear picture whether we need to go in for surgery or not. And all these children can have an underlying lung compromise, they can have intracardiac defects. But remember, the question and for exam point of view, as I already stressed upon in all our discussions on pectus excavatum, if they are to ask one question, is going to be only NUS procedure, which is used for pectus excavatum, and that has been clearly asked in the examination. So this NUS bar is usually removed after 2 years and once the stabilization happens. So this is the first question. The second question is on the thickened pleura. This is actually part of a cardiothoracic question, but I've put this up today to emphasize upon the fact that empyema thoracis can also occur in children. Though this is not a part of our routine pediatric surgical syllabus per se, but still empyema can also occur in children. Okay, so usually it starts with a pneumonia. This pneumonia forms a sympneumonic effusion, and this sympneumonic effusion slowly progresses into first stage, stage 1 of empyema, which is an exudative phase, and subsequently in the 4 days to 2 weeks it goes into a stage known as fibropurulent stage, where you will have fibrinous strands running through your pleural cavity, and subsequently they go on for a phase known as organizing phase, that is after 2 weeks, where there will be thick peel. So initially what was a parenchymal disease, a pneumonia causing parapneumonic effusion, now goes into a thick peel and forms a restrictive component. So the treatment of choice is going to be a thoracoscopic decortication. So you remove the diseased pleura. So stage 3 of empyema, where there is a thickened pleura causing a restrictive disease, you remove the thick peel of pleura, the lung will expand adequately. So this is a classical CT, a history of pneumonia, along with the CT revealing this finding is going to give you a pneumonia complicating and resulting in an empyema. So though this is usually emphasized in adults, yes, children can also have empyema. So this is for you to have in mind. Okay. The next question, which we already discussed in all our classes, is pseudo kidney sign on longitudinal axis. We all know that is going to be a 6 months old child who presents to you with intermittent colicky pain. Intermittent colicky pain classical intersusception. Intersusception is where you get a pseudo kidney sign and longitudinal axis in ultrasound. Interception is an average age group, though between 6 months to 2 years. Some books say 3 months to 3 years is your age group, but the average age group is around 6 months, where you get a Peyer's patch hyperplasia. The child presents to you with intermittent colicky pain. The 6 months old child takes both the foot into the abdomen and then cramps it during pain and then relaxes. So, intermittent colicky pain, a classical of interception. At later stages, this interception can form red currant jelly stool. Red currant jelly stool is at the later stages of interception. And though Peyer's patch hyperplasia is going to be your most common cause around 6 months of age, at elderly age groups, there can be lead points. There can be PLPs or pathological lead points, and the commonest one is going to be your Meckel's diverticulum. So this is how the interception happens. You can see the small bowel loop going inside and causing an interception, but this is what we are looking at. So the ultrasound is going to be giving you a bowel within bowel appearance. This bowel within bowel appearance is classically named into different nomenclatures: a donut sign, a target sign, bullseye appearance, pseudo kidney appearance, or threshold appearance in your long scans. And earlier we used to do bariminima, which gives a claw sign or a pincer sign or a coil spring appearance. But at present, the investigation of choice for a child who presents with intermittent colicky pain, suspecting intersusception, is going to be ultrasound. Ultrasound is classically going to give you a bowel within bowel appearance, which is known as various names. Exam point of view, pseudo kidney appearance is what is being done. So early referral of interception, simple hydrostatic or pneumatic reduction, you'll be able to have a disease cure. Whereas in later stages, you need to do a laparotomy and reduction, manual reduction, or in very late stages, you may need to do a resection, anastomosis, if the bowel has gone for gangrenous. But always remember, in delayed age groups and later age groups which don't fit in this classical age group criteria, always think of pathological lead points when it comes to intersusception. So pseudo kidney sign, the ultrasound is going to be your gold standard diagnosis, and it is bowel within bowel appearance which gives a pseudo kidney appearance. So this is with regards to your third question. So this is another question which was put up in our recent classes with regards to images of extrophy epispadias complex. This is put up because this was there in your latest edition. And epispadias, you all know, we have discussed about hypospadias, where the opening will be at the ventral aspect. The opening will be at the ventral aspect. It will not be at the tip. It can be at varying degrees, where it can be a distal penile hypospadias, mid penile hypospadias, or a proximal penile hypospadias. If the opening is on an abnormal position on the dorsal surface of the penis, it is known as epispadias. So epispadias is a rare dorsal penile defect with an opening whose upper limit lies anywhere from the penopubic junction to the glans. It can again be a proximal, mid, or a distal epispadias complex. And this epispadias may be a part of your bladder extrophy. So your bladder will be completely out, the lower abdominal wall will be deficient. You can have an extrophy epispadias complex. So this is the classical epispadias. You know that the opening is not at the tip, it is an abnormal position on the dorsal surface of the penis. It can be of varying degrees. Similarly, you can have an extrophy. You can have a complete extrophy, cloacal extrophy, or just a bladder extrophy. So we all know the entire GIT will be formed, genitourinary system will be formed in a single opening called as cloaca. And this cloaca is now split up into two portions, a urogenital portion and an anorectal portion. When this separation is not proper, then the entire cloaca is projected outside, known as a cloacal extrophy. Whereas if this happens properly, only your bladder is projected outside because of a deficient lower abdominal wall, it is known as extrophy complex. And this extrophy or the bladder extrophy, when combined with an epispadias where you have an abnormal opening on the dorsum of the penis, it is an epispadias extrophy complex. So this is the picture which was there in your examination, epispadias extrophy complex, because this was there as a part of your recent editions. And we also have to have an emphasis on cloacal extrophy to discuss in your classes where the entire cloaca is projected outside. And then this is again what we have discussed, a torticollis or a rhinate. But the point of view which we have already discussed in our classes is plagiocephaly. Plagiocephaly, also known as flattening of the skull. Flattening of the skull in the newborn. Why does it flatten? It may be because, so you can see this is the classical presentation of flattening of the skull. Why does it happen? It can be because of an abnormal suture fusion synostosis or a physiological remodeling. Physiological remodeling is what we see in a day-to-day practice. And as we have discussed in our classes, torticollis because of a wry neck. This may be because of several reasons, as we have discussed in all our presentations. This can be because of a pathological cause. This pathology may be because of a fibrotic sternocleidomastoid, and hence the flexion doesn't happen adequately and the head is tilted to one side, and this tilting of head to one side on chronic compression can cause flattening of the skull, causing plagiocephaly. Or this can be because of strabismus squint, or this can be because of your vertebral dislocations. Your vertebral dislocations again can cause these anomalies, and subsequently you can have intracranial anomalies, or you can have a part of other very local symptomatologies such as lymphadenitis or other local causes where the child will not be able to flex it to the disease side. Hence they will have their head tilted to one side, and this tilting to one side, flattening of the skull, a characteristic feature known as plagiocephaly. So we have discussed in a class in torticollis, yes, wry neck or torticollis, where there may be abnormal fibrotic sternocleidomastoid causing abnormal flattening of the skull due to abnormal positioning. Just remember the term as I've given in your presentations also. It is plagiocephaly or flattening of the skull. Okay. And again, there was an image of hypertrophic pyloric stenosis. As we have already discussed, most of your conditions, surgical conditions to discuss, presents with bilious vomiting. So bilious vomiting is where your obstruction is beyond the second part of duodenum. Whereas if the obstruction is proximal to the second part of duodenum, we have non-bilious vomiting. And the classical history I've told you in all your presentations is this will be a 4 weeks old term male child with non-bilious projectile vomiting. Non-bilious projectile vomiting, 4 weeks term male child, classically known as hypertrophic pyloric stenosis. This hypertrophic pyloric stenosis, your investigation of choice is going to be an ultrasound. That is going to be a gold standard. You look at the pyloric muscle thickness and the length of the canal. So 4 and 16, 4 into 4 is 16. That is what I taught you in your classes also. Remember, 4 is the thickness and the 16 is the length of the pyloric channel, which gives you a classical diagnosis of a hypertrophic pyloric stenosis. This is going to behave like any gastric outlet obstruction. Electrolyte abnormalities are going to be like a gastric outlet obstruction. The treatment is going to be a pyloromyotomy, a Ramsted's pyloromyotomy. This is the pyloromyotomy image where you can see a thickened pylorus, the mucosa is bulging out. A pyloromyotomy, as I told you, a hypertrophy of the circular muscle of the pylorus, and you'll have on clinical examination an olive-shaped tumor in the epigastrium, classical olive-shaped tumor in the epigastrium, and the pyloric muscle thickness on ultrasound is going to be 4 millimeters, and the pyloric channel length is going to be approximately 16 millimeters, and the treatment of choice is going to be Ramsted's pyloromyotomy. Just remember the picture. Even your presentations, I've put up the picture only from a textbook so that you will have a clear picture. And this was the picture put up for examinations also. So you will get a clear picture of a Ramsted's pyloromyotomy. It has been done for a hypertrophic pyloric stenosis, a 4 weeks old term male child who presents to you with non-bilious projectile vomiting. This is again a laparoscopic picture we discussed in your class. Next, this was what was asked in examination, a pediatric Glasgow coma scale. Though this is not a part of the pediatric surgical perspective of your general surgical textbooks, but still I put this up as a part of the discussion so that you will know an overview of your pediatric Glasgow coma scale. Though this comes under trauma per se, this has not been discussed in our pediatric trauma chapters of your surgical textbooks. This is what was given. So on eye opening, the spontaneous eye opening, a score of around 4. Your motor response, where there's a flexion withdrawal, a score of 4, and inappropriate words, but the question asked was persistent inappropriate crying, where 3. So 8 plus 3 is going to be 11. So this is your pediatric Glasgow coma scale. You can just see an overview of the total pediatric Glasgow coma score and your various responses depending on the age group of the child. So greater than 1 year or less than 1 year, you will have all of this findings put together. So though the question was not appropriate as to what age group we were not able to trace through the question, but based on your age group, you will be able to put up on either of these. So spontaneous eye opening is going to have a score of 4. Your motor response, flexion withdrawal is going to be a score of 4. And again, an inappropriate crying is going to be a verbal response score of 3. So these are the various parameters with regards to your pediatric Glasgow coma score. But we all know with regards to pediatric trauma, the new points which they were there in our textbooks are regards to abnormal clotting or abnormal evolution of DIC because of the abnormal clotting factors in infants and in pediatric population. And further, with regards to solid organ injury, it is going to be similar to adult practice where we only when there is a vascular pedicle avulsion we go in. Otherwise, most of it is only conservative approach. But remember, as I've discussed or stressed in all your discussions, there is something known as patterned aberration. Patterned aberration, or whenever you get hit by some object, when the object makes an impression on the abdominal wall, there is always a possibility of delayed onset of perforation. There is always a possibility of delayed onset of perforation known as London sign or a patterned aberration. London sign or a patterned aberration where you can have a delayed onset of perforation is always admit the child. This is the there are only certain factors which segregate adult trauma from pediatric trauma, like the children have very malleable ribs, so they need not have a rib fracture to have an underlying lung injury. One. Number two, there are certain instances known as SIWORA, SCIWORA, where the children can have spinal cord abnormalities without any radiological abnormalities visible, known as SIWORA, SCIWRA. These are certain points which differentiate an adult trauma from a pediatric trauma. But what we need to know is regards to pediatric Glasgow coma scale, and just have an overview of this picture to get an idea of the scoring pattern in children. And again, this was another image which was discussed in all our classes with regards to tracheoesophageal fistula, esophageal atresia. As I told you earlier, any newborn who presents to you with a breathing difficulty, you look for other symptoms and signs when they have a drooling of saliva, cyanosis, breathing difficulty. Your diagnosis is going to be tracheoesophageal fistula. Whereas you have a breathing difficulty, you look at an X-ray, you have paucity of bowel gas in the abdomen and a lot of bowels clumped in the chest, you think of congenital diaphragmatic hernia. But for exam point of view, as I've stressed in all your classes, a newborn, breathing difficulty, drooling of saliva, cyanosis, you think of tracheoesophageal fistula or esophageal atresia along with tracheoesophageal fistula. You take an X-ray, you put an NG tube. This NG tube will not be able to pass the NG tube further the atretic segment. You can see there will be coiling of NG tube on the proximal esophageal pouch, or you will not be able to pass the nasogastric tube below the atretic segment, or a coiling of nasogastric tube on the atretic segment, giving a classical diagnosis of an esophageal atresia with or without tracheoesophageal fistula. This is the classical picture. You can have a proximal blind ending esophageal pouch. You put in an nasogastric tube, it will coil at the proximal pouch. And the commonest type is type C. Commonest type is type C, where the distal esophagus communicates with the airway with the tracheoesophageal fistula. So proximal esophageal atresia along with the distal tracheoesophageal fistula, classical of type C. This is the most classical type of type C. Whereas you can have a pure esophageal atresia where you will have a blind ending proximal and distal pouch. A blind ending proximal distal pouch, you take an X-ray, you will have a gasless abdomen. You will have a coiling of nasogastric tube on top with a gasless abdomen, classical of pure esophageal atresia. Whereas type C is the commonest type where you have a proximal blind ending esophageal pouch and the distal esophagus communicating with the trachea, causing a tracheoesophageal fistula, which is type C, which is the most commonest type. So the X-ray is what they've been asked in your examination. And there is another type called as H fistula, where you can see the lumen is adequate, whereas there will be an abnormal communication known as H fistula. There's another type. So these mutations have been mentioned in recent editions, so just put up. But remember, the examination questions are going to be straightforward only. You just put up a picture of esophageal atresia along with the distal tracheoesophageal fistula, which I've already discussed in your classes, and we know the commonest presenting feature is going to be blind ending upper esophageal pouch causing a drooling of saliva along with respiratory difficulty and cyanosis, a classical of a esophageal atresia. Then This picture, which I've already put up in our classes, a distal colonography image of a rectourethral fistula. We know anorectal anomaly in children, where the child will present to you with failure to pass of meconium at birth. So when the child fails to pass meconium within 24 to 48 hours after birth, you look at the anal opening. You look at the anal opening, there will be an absent anal opening. An absent anal opening can be of different grades, as we have discussed in the classes, high, intermediate, or low. If it is going to be a low, then probably you will have the meconium speck visualized in the perineum. You just do an anoplasty or local procedure. So the anocutaneous fistula is just opened out to the exterior. This is a low anorectal malformation, whereas where there is a high lesion with a flat perineum, where you have an absent anal opening. So whenever you have an absent anal opening, this colon has to find a way. This colon finds a way to the urinary system, and this finding a way through the urinary system is through a fistulous communication. This fistulous communication may be at the bladder neck, or at the proximal or distal urethra, based on the level of lesion. If it is going to be a high anorectal anomaly, where most of your bowel is only developed on at the proximal most limit, your distal bowel is paucity, your neurological segments, your muscular segments, and your bowel distally has not formed well. The developmental abnormality has been gross. Hence, you have a proximal bowel which is communicating to the bladder neck, or your proximal most urethra. Whereas if it is an intermediate anomaly, it is developed somewhat okay, the neurological system is okay, your levator muscle is also partly okay, and that time your bowel can communicate to your distal urethra, a rectourethral fistula. So anorectal anomaly may have communication based on the level of anomaly. How do we say the level of anomaly? It is based on the levator ani muscle. Based on the levator ani muscle, when it is the bowel gas shadows above the levator ani, it is say high. Within the levator ani muscle, it is intermediate. Below the levator ani muscle, it is low. If it is a low anomaly, it just opens out by a speck of meconium. We do an anoplasty. If it is an intermediate or high anomaly, this can have a communication with the urethral system. In fact, this will have a communication with the urethral system, and based on the levels, this may be high or intermediate. This is the picture giving you a classical rectourethral fistula in anorectal anomaly. This is what we were discussing about in our classes also. To assess the level of anomaly, we take an X-ray known as cross prone table lateral view. Cross prone table lateral view. Child is placed in a prone position. A cross table X-ray is taken, a cross prone table lateral view. And as I told you earlier, it is going to be based on levator ani muscle, where we're going to classify as high, intermediate, or low. And the classical radiological description is something known as a PC line or a pubococcygeal line, which gives us the upper limit of your levator ani, eye line, which gives us a lower limit of your levator ani muscle. When the bubble gas shadow is above the PC line or above the upper limit of levator ani, it is a high anomaly. When it is between the PC and eye line or within the levator ani muscle, it is an intermediate anomaly. When it is crossed the eye line, then it is a low anomaly. So low anomaly, as we have discussed, low anomaly, the treatment is going to be just anoplasty, whereas an intermediate or high anomaly, we're going to do it as 3 stages. The stage number 1 is going to be a diverting colostomy. Stage number 2 is going to be a posterior sagittal anorectoplasty. As we have seen in the picture, there is an abnormal communication between your GIT and the urinary system. So posteriorly, we make a sagittal incision, and then you disconnect this communication between the GIT and the genitourinary system. You disconnect this communication. This rectal urethral fistula is disconnected, and the neoanal opening is created. So the first stage is going to be a diverting colostomy. The second stage is going to be a posterior sagittal anorectoplasty, where a posterior sagittal incision is made, a neoanal opening is created, and abnormal fistulous communication between the rectum and urethra is taken down. So colostomy, a posterior sagittal anorectoplasty, followed by a colostomy closure. This is what is done for an intermediate and high anorectal anomaly. But exams, they've asked this classical picture of a rectourethral fistula, which is evident in children with an intermediate or a high aneuric anomaly, classically given by means of Levi-Trani. Diagnosing the level of anomaly at the newborn period is by something known as a cross-prone table lateral view. It's all been discussed in examination. So, our previous presentation also, we've been emphasizing and all these parameters point by point. Okay. And then this is, as I've stressed up in all our classes, there are 2 points which we always have to remember in pediatric surgery. Point number one, any newborn who presents to you with bilious vomiting, it has to be malrotation unless proved otherwise. Number one, any newborn male child who presents with a distended bladder, dribbling of urine, it is going to be posterior urethral valve unless proved otherwise. So the classical picture, a bilious vomiting, a double bubble sign, and a gasless abdomen. As we have discussed in our classes, double bubble sign can be a part of a duodenal atresia number one, annular pancreas number two, malrotation with volvulus number three. Malrotation with volvulus cap happens here. So it will be a stomach and the duodenum. Malrotation with volvulus is going to be a point number three. So whenever volvulus happens, as we know, how do you evaluate a child with bilious vomiting? You have had your diagnosis of either duodenal atresia, annular pancreas, or it is going to be a malrotation with volvulus. Next investigation is going to be an ultrasound. Ideally, in X-ray, on X-ray, we a double bubble sign. Once you have confirmed the double bubble, the next investigation is going to be an ultrasound. On ultrasound, we are going to see if there is an alteration of SMA and SMV axis. When there is an alteration of superior mesenteric artery and vein axis, usually vein should be to the right. Whenever it is altered, we think of malrotation. The investigation of choice is going to be an upper GI contrast study. On upper GI contrast study, you see a classical whirlpool pattern. The classical whirlpool pattern, when there is volvulus, the most important point is your position of DJ flexure. DJ flexure usually should be to the left of the spine. When it is over the spine or to the right of the spine, it says that there's an abnormal fixing of the DJ flexure, which is classical of malrotation. Along with it, in upper GI contrast, you get a whirlpool sign. It is malrotation with volvulus, mandating emergency laparotomy or laparoscopy. The treatment of choice is something known as a LADS procedure. LADS procedure is treatment of choice for malrotation. What do? We derotate the volvulus. Number one, derotate the volvulus. These are abnormal LADS bands compressing on the duodenum. Abnormal LADS bands compressing on the duodenum are divided. Then subsequently, you widen the duodenocolic isthmus. You can see the duodenum and colon very close to each other. You widen the duodenocolic isthmus so that the entire small bowel, which is hanging on a small pedicle of a superior mesenteric artery, is now widened. When it is hanging on a small pedicle, there are chances of volvulus, but once they are widened, the chances of volvulus are negated. So you derotate the bowel, you release the LADS bands, you widen the duodenocolic isthmus, plus or minus an appendectomy, a classical LADS procedure. So newborn, bilious vomiting, X-ray double bubble sign, gasless abdomen, you're thinking of malrotation with volvulus. You do an ultrasound where there is an alteration of SMA, SMV axis. The gold standard is going to be an upper GI contrast study where you can see a classical whirlpool sign. Along with it, you're going to see an abnormal DJ flexure. The treatment of choice is going to be LADS procedure. So it's treated early, you'll be able to save the bowel, but it's gone late, then obviously the entire small bowel is going to go in for complete gangrene and it's going to be very difficult to be compatible with life. So early referral, malnutrition with volvulus, LADS procedure, child is cured. Whereas delayed, then you can go in for complete gangrene. So newborn bilious vomiting, always think of malrotation. And when there is a gasless abdomen, think of malrotation with volvulus. Okay, this is a laparoscopic picture. So now this was again another picture which is put up with regards to foreign body, a child with progressive dyspnea and previous hospital visits for similar complaints. Always take an X-ray, think of a foreign body. Foreign body, we have discussed in our classes extensively with regards to GI foreign bodies. They may also be foreign bodies in the aerodigestive tract. Foreign body in the aerodigestive tract can cause dyspnea, which may become progressive. Always take a chest X-ray because children may tend to not reveal a classical history. There can be a variety of foreign bodies starting from peanuts to whistles to other radiopaque foreign bodies. So progressive dyspnea in a child or an acute onset of dyspnea which is progressing, always think of foreign body. Take an X-ray, you'll be able to find a foreign body 1 or you'll be able to find an atelectatic lung where the foreign body has plugged the bronchus to that specific segment of the lung. So acute onset dyspnea, which is progressive, always think of foreign body in children. Whereas in cases of GI foreign bodies, we know the most important foreign body which we always discuss in a class is going to be a button battery. So button battery in the esophagus needs urgent removal, because delayed removal can cause tracheoesophageal fistula, can cause bleeding, can cause various complications. So button battery in the esophagus, urgent removal. Button battery in the stomach, you wait for 24 hours, it doesn't pass through, you remove. Whereas button battery has passed through the stomach, you wait for spontaneous expulsion, but still you'll have to tell the parents that we don't know how long has it been lodged in the esophagus. So these children can have long-term side effects, or they can have delayed side effects. In the next 1 week, we'll have to ask them to look for signs of choking, signs of breathing difficulty or aspiration, and they have to report immediately to the hospital. So these are all what has been asked for examinations. We have covered nearly everything in our presentations, and really happy to note that all of you had, most of you who had messages have got all of your pediatric surgical questions right, and we look forward to taking your queries anytime in the near future, and we'll be open for discussion, and we hope and pray that you get the expected super specialty seat of your choice and come out with flying colors with happy messages, as has been happening for all these years. Thank you one and all for your patient listening, and all the very best for your future endeavors. And we'll be very happy to meet a lot of new pediatric surgeons who will come up and take up this field in the future. Thank you one and all from the entire team of RRM and DocTutorials. Thank you one and all. Yes.
Thank you, sir.